This program is brought to you by Emory University.
Today, it's my distinct privilege to introduce my friend and colleague, John Wilkins from Northwestern. John is a cardiologist and also an epidemiologist who's become well known for his work on lifetime risk in cardiovascular disease, particularly in young individuals. Now, John graduated from Tufts University, where he was the, I think, self-proclaimed smallest down lineman in D1 college football. D3. All right. Yeah. Okay. Very well. Then after getting his MD at Wake Forest, where he was AOA, he joined me at Northwestern in the incoming intern class, now a remarkable 20 years ago. So John is both an outstanding researcher and teacher. He's got over 100 publications to his name, and I was impressed to see that nearly 80% or more than 80% of those are actually pure scientific papers, not other types of articles. And he's currently got multiple R01s. He's been on multiple significant AHA committees like lipids and scientific statements for lifetime risk. He's also developed a reputation at Northwestern as a fantastic teacher. He's got over close to a dozen teaching awards from the House staff there. I could go on and on, but I will digress here so we can go ahead and get started for what I know is going to be a very interesting talk.
All right, good morning, everybody, and thank you for joining us, everyone here in person and everyone online. So without further ado, I'll get started here. So anyway, what I wanted to talk to you today is about really assessment and mitigation of lipid-associated risks in young adults. This is a population for which the effects of lipids on long-term risk, it turns out, are really quite large. But we have really little guidance as to what to do with this population. So this has been a focus of interest of mine for years. These are my disclosures, or from the R01. These are not relevant to this talk at all. So we're going to start off actually with a discussion of taking a life course perspective on prevention and what I really mean by that. Review some of the data that supports the importance of early life risk determinant exposure on long-term risk in CVD-free health span. I'm going to talk about a determinant versus risk framework. In fact, that's really not one versus the other, but how the two can be complementary in understanding cardiometabolic health in young adults. Talk a little bit about some of the different techniques we have for measurement and assessing atherogenic lipids for individuals less than 40. And then I'm going to finish up with a few clinical recommendations for assessment and mitigation of risk. So it's a life course perspective on prevention. Like, what do I mean by that? And by life course, I'm really talking about a framework with which to better understand the development of disease, to develop questions about research. But I think this can also really help inform clinical decision-making for patients, particularly young adults. So in this model, I'd argue, cardiovascular disease starts with a propensity. This is a propensity to develop determinants and our propensity to develop actually risk later in life. This is determined, of course, by genetics and by environmental exposures that occurs often in utero and in early childhood. And we're learning a lot more about the importance of environmental exposures, early life stressors, et cetera, social determinants of health, and how they may shift the trajectory of someone's health across their life course, either through direct somatic effects and or effects on brain development that seem to predispose some individuals to the adaptation of adverse health behaviors that have consequences later in life. But the point being is that these trajectories that we see people on in midlife and later probably have their origins actually in pediatrics. Then at some point in the life course, people then many go on to develop the determinants of cardiovascular risk. For the purposes of this talk, I'm going to focus on atherogenic dyslipidemia. There's no clear age cutoff at which this happens. And unfortunately, in the United States, we're seeing this occur earlier and earlier, which is very problematic. We'll review some of those literature. And for the purposes, by the way, of this talk, I'm going to define young adulthood as 18 to 39 years old, which is a little painful for me now that I'm outside of that range. But in that, people then progress through this phase of sort of determinants into, at some point, developing actually either subclinical cardiovascular disease or 10-year risk. This is where, the middle-aged adult, we have a lot of data to, I think, help guide clinical decision-making in this population appropriately. This is where we focused our initial efforts, as we should. These are the people that were the highest kind of near-term risk. And we have, I think, a very effective framework for making decisions, certainly about primary prevention and initiation of lipid therapy. And then at some point in the life course, people get closer to the end, again, the end of their life course, where you need to start considering other causes of morbidity or competing risks of death to help make decisions, certainly about the appropriateness of continuing primary prevention interventions. There is clearly no age cutoff here, and this is actually such a more complex and sort of individualized decision. But for today, we're really just going to focus on the young adult window. Okay. So why am I so interested in young adulthood and early life risk factors? And, for the trainees who may be here or maybe listening, I like to kind of share this story about how I got to got where I am, and I'm focusing on the questions that I've been particularly interested in. So when I was a fellow, Jarrett Berry and Don Lloyd-Jones, who's been a shared mentor of the two of ours, were working on this analysis in the Lifetime Risk Pooling Project. The Lifetime Risk Pooling Project, basically what they did is they took individual level data from 20 different cohort studies and kind of merged them all together. And this allowed them to describe patterns of risk, or us to describe patterns of risk across the adult life course. And so in this analysis, what they did is stratified individuals by risk factor burden at age 45. This analysis was completely agnostic to what happened after age 45. And the red line here are people who had 2 or more risk factors at 45. And the bar here is not particularly high. This is either people that were smoking, had blood pressure greater than 140 over 90, or on medications, tobacco use, or diabetes. And then the green line were individuals who had none of those risk factors. And so when I read this the first time, I said, okay, so this shows that people who have risk factors at 45 have higher risks, which is true. And I wasn't particularly, I said, I thought we, kind of knew that. And it's one of these things, I had to go back and read it again before I think the full magnitude of what they were showing here really kind of sunk in. And so I'm going to show you, it's not, again, the pattern of association, I think we knew, but it's the magnitude of effect. That's what really hadn't been described as clearly until this analysis. And so let's take someone who's 75 years old. If we compare the risks, let's say in the group, this is, by the way, risk for CVD death over the life course. And so the red line there at age 75, you're looking at a risk for CVD death, we'll call that about 28%. This is absolute event rates, by the way. But if we go to the green line, we're looking at risks of around 2%. Now, the difference between those, that's a 14-fold difference, or a hazard ratio of 14. That's a absolutely massive effect. But I like to turn that on its head, right? What is the benefit of staying in that green group? And that hazard ratio is about 0.07. We don't have any medications or any of our interventions that come close to that kind of efficacy. So the importance, or effectiveness in this context, the importance of staying in that sort of optimal cardiovascular disease risk group, at least by middle age, is absolutely massive. I think another implication of this is if you look, if you take when does someone reach a sort of 15% risk, which is where that arrow is, clearly if you have lower risk factor burden, that's occurring much later in the life. So this is probably translating into substantial differences in longevity, right, across individuals, which is not terribly surprising, but I was curious about how long is that on average? And I'll show you some data that gets into that. And I'd say the last main point, as I really thought about this more, was that if risk factors at 45 are so important, right, it implies that a lot of the action, if you will, is occurring before 45, right? Like what's actually happening to get people to that age point with risk factors or without risk factors? And we'd probably get huge benefits if we really focus on that group. So I told you I was interested in as I saw these data, I was aware of them obviously before they were published, and said, that's really interesting. What happens if we add heart failure to the mix? Obviously, that's a disease with a lot of morbidity, particularly in older adults. And we look at the relationship to risk factors. And maybe instead of looking at it just in terms of like a risk number, I think what a lot of patients want to hear about is, how long am I likely to live, right? What are the benefits? And I think saying a sort of expected, survival or average difference in survival, I think is another way to communicate with our patients that can really help drive home the importance of prevention or primordial prevention in this context. And so what we did here is we used the same schema of stratifying people at 45. And what we showed were that individuals who, again, had sort of optimal risk factors at 45, as we defined it, at least by that criteria, lived on average 14 years longer. There's another nuance there to this, and that the dark bars are the amount of years lived without cardiovascular disease. The gray bars are the amount of years lived after having a cardiovascular event. So not only were people living longer, but they were living longer and healthier lives, right? So, and I think this is, by the way, one of the things I use when patients come back to me and say, hey, doc, I got to die of something, and say, you're right. And the question is when, and the question is, how healthy do you want to be before that happens, right? And so I think this is a really important message and thing to keep in mind when we counsel people about the importance of primordial prevention. Okay. So if cardiovascular risk factors are so important, how are we doing in the United States in terms of maintaining optimal cardiovascular health or optimal risk factor levels? And the answer is not well. And I know this doesn't surprise a lot of you, but these are data from NHANES from 2023 that really show what I would say are unacceptably high levels of cardiovascular determinants. And so for individuals with blood pressure greater than 140 or 90, we're looking at prevalence rates. These are 18 to 40-year-olds. North of 10, about 12%. The diabetes were around 5 to 6%. BMI greater than 30, as you all know, is really quite high, around 40% in the United States. Dyslipidemia was sort of marked on as potentially a slight win, in that it is slightly downtrending at 38%. But that's using a threshold of 200 milligrams per deciliter, which I'm going to show you some data a little later. In my view, that's actually too high of a bar. In fact, I think that bar should be lower to define dyslipidemia in a young adult. So I would argue the true prevalence rates of at least what I would consider a concerning dyslipidemia in young adults is actually substantially higher. But nonetheless, the risk factor prevalences in the United States in young adults represent the public health emergency, in my view, and I know the view of others. And we have projected at least cost burdens in 2035, and I think it's like $1.1 trillion or some just astounding number. I mean, this is coming, and it's troubling. Okay. Just briefly, for those of you who don't think about lipids every day, I'm just going to do a very, very brief kind of lipid physiology review that's relevant to this talk. As you all know, sort of triglyceride and cholesterol are hydrophobic, right? So in order to travel through the blood, they get packaged in lipoproteins, which have a phospholipid monolayer. Each lipoprotein, by the way, has one molecule of apolipoprotein B on it. So if you measure an ApoB concentration, you're measuring the total number of the atherogenic particles in one individual, versus measuring the cholesterol or triglyceride content. Gives you some insight into the number of particles, but really just gives you the mass of cholesterol. Now, those would be entirely the same thing if basically particle size were the same and the distribution of the LDL particles and LDL particles were the same across individuals. And for the most part, they are, but there is a little bit of variation there. And that can be relevant to risk estimation, which we'll talk about a little bit later. Fair amount of data in middle-aged adults that ApoB might have a slight edge over LDL or non-HDL cholesterol in terms of risk estimation, but that's really not the main focus of the talk, but we will touch on it. But I just wanted to have that kind of background. I think another thing to keep in mind is whenever we measure a cholesterol level or an ApoB, whichever assay you want, you're taking a snapshot in time, what is actually a very dynamic and complex equilibrium, essentially of synthesis of atherogenic lipoproteins and clearance of atherogenic lipoproteins. We know some about the factors that drive synthesis, certainly overnutrition, fatty acid intake, et cetera. But we don't understand that sort of end of the equation quite as well as we do clearance, which, as you all know, works predominantly through the LDL receptor, which is our main target for most pharmacotherapy that lowers LDL or lowers atherogenic lipids. Just as a side, my group, we do some work looking at sort of a niche form of proteomics called top-down proteomics and some epigenetic analyses to try to better understand other factors that might be driving this equilibrium towards atherogenic dyslipidemia. Those results aren't quite ready for prime time, so I'm not sharing them today, but I just want to let you know that's sort of another focus of our group. And then we also do a lot of more traditional epi, as you can see there, things like, diet, physical activity, lifestyle, body composition, et cetera, and its role in mediating levels of atherogenic lipids in young adults. And I'm going to talk about some of those data today and how I think they're relevant to the care of patients. Okay. So why am I so fixated on lipids? Well, I do take a very lipid-centric view of atherosclerosis initiation propagation across the life course. And a lot of my work is really kind of fundamentally anchored in the biological model of the response to retention hypothesis. The central concept here is that atherosclerosis is really the result of the entry of atherogenic lipoproteins or ApoB lipoproteins into the subendothelial space, the retention there, and the body's chronic inflammatory response to those retained particles. And that's really the core, if you will, the core process that leads to the development of atherosclerotic plaque and downstream events. That does not mean that other risk factors aren't important. They're vitally important, no question. Almost everybody in the United States has enough atherogenic lipoproteins to cause a plaque in the wrong circumstances. And our other risk factors, of course, things like hypertension, tobacco use, certainly diabetes, central adiposity, and to some extent, I'm sure genetics, probably affects the susceptibility of the artery to the pathogenic effects of atherogenic lipoproteins, either through making the endothelial layer a little bit more permeable and or potentially, I don't know, making apolipoproteins a little bit more adherent, if you will, to subepithelial proteoglycans. We don't know all of that biology. But essentially, we have this dynamic shift between entry and exit of lipoproteins, but some of them get stuck there, and that sets up inflammation. There's also certainly differences across individuals about the type of and extent of the inflammatory response that they have, of course, right? And so people with chronic immunologic dysregulation, like chronic HIV infection, et cetera, we know over time from epidemiological studies are at much greater risks of the development of atherosclerosis at young ages. So again, this process is central and core, but of course, certainly not the only important factor that determines cardiovascular risk, which I know you are all aware. Okay. So let's talk about, again, back to this life course model. I could say, John, why don't you just apply the risk approach to young adults and leave it there? We'll just calculate 10-year risk or 20-year risk and say, we'll make a decision, or 30-year risk. We'll make a decision about who, what therapies we should administer to patients. And we may get there at some point, but I do want to talk a little bit about some of the advantages and disadvantages of absolute risk estimation in making decisions about at least with pharmacotherapy. I think it's advantageous for everybody from a risk communication standpoint. So I'm not anti-risk estimation, please, by any means. But one of the main advantages of absolute risk estimation is sort of it allows you to compare the absolute benefits and the absolute risks of an intervention. And this is one of the reasons why I think when this approach was developed, it was particularly attractive to the guideline writers. And there's a lot of truth to that. It does a really nice job of integrating risk information across multiple risk factors, which it turns out we know that individuals don't do particularly well. So that's, I think, another really big advantage. And it really can aid in patient risk communication. A lot of people obviously don't have a real understanding of what their absolute risks are or how this translates into average survival. We have some kind of general understanding, but we need to be sure to educate our patients about that. But what are the disadvantages with young adults? Well, again, I don't think there's a disadvantage in terms of risk communication. I think we should do that. I think that's great. But can we pin all of our decisions upon a risk calculator? For a young adult, I am not optimistic that that will ever work. I'm not sure that we can say, hey, I know what's likely to happen to this person in 30 years. That's just a very difficult thing to do. There's a lot of stochasticity, randomness, who knows, treatments change, et cetera. I'm not sure we can ever do that. And I give the example of, I doubt I'm ever going to have enough confidence in, let's say, a low risk estimate to say, oh, I can ignore this cardiovascular risk determinant that's present in this individual. Now, not that people who are fans of lifetime risk, and I'm one of them, by the way, ever thought that that was how it should be used, but I want to be clear that, we may not have that kind of degree of confidence. I would say at present, we don't have actionable thresholds. We may in the near future, but for what is the absolute level beyond a 10-year risk of greater than 7.5% or 5% in a young adult? But they got to have really abnormal risk factor levels to get there, which we would be treating anyway. What is the optimal time horizon? 10 years, 15, 20, 30, 35? We don't know yet. And I want to be sure that although it's perfectly reasonable and helpful to start maybe with absolute risk, but you can't stop there. And it can sometimes become uncoupled from biology. If someone has a risk estimate, you have to ask yourself, what is it that's driving the risk, right? What can I intervene upon, right, to get their risk as low as possible? So I just wanted to sort of, and again, introduce and touch on some of those strengths and limitations. All right, so we're gonna go back to lipids here. All right, John, so you fixated on atherogenic lipids as sort of your risk target or one of your risk targets in young adults. Why? And what do we know about atherogenic lipids and their role in cardiovascular risk development or atherogenic lipid exposure in young adults? Well, a fair amount. This is one of the sort of earlier papers I've read on this by Emory, fantastic work from, I think this is Framingham Offspring, where she looked basically at decades of life exposed to a non-HDL greater than 160 prior to age 55. And what she showed was there was a doubling essentially of cardiovascular event rates per decade spent exposed to a high level of non-HDL cholesterol. Okay, so certainly supporting the premise that early life exposure has long-term effects. And then more recently in 2020, I believe, 2020, this came out of the Cardia cohort. So I work a lot with the Cardia cohort. For those of you who don't know, Cardia is one of our cardiovascular cohort studies that enrolled adults at between 18 and 30 back in 1987, and has now been following them for over 35 years. So this is a great cohort if you're really interested in, young adulthood risk factor exposure and its long-term consequences. And anyway, what Dr. Domansky did here is calculated cumulative exposure to LDL, but then adjusted that for the lipid level at age 40, right? And what they found is even after you adjusted for the lipid level at age 40, there was still a stepwise increase in cardiovascular risk amongst those who had higher quartiles of cumulative exposure, right? So this sort of implies that there may be some kind of persistent effect, or sort of the inverse of a legacy effect, that even if you account for what someone's lipids are at 40, the exposure that they had earlier in life, right, still may be contributing to longer term risk. Again, supporting the concept, at least, that we need to do things to reduce that exposure earlier in the life. That doesn't necessarily mean medications, to be clear, but we need to at the very least be aware of this accumulating risk that can be occurring across early adult life. You say, okay, well, I talked about ApoB earlier, and we do have some data showing that ApoB in middle-aged adults has a slight edge over non-HDL and LDL cholesterol in terms of risk estimation in middle-aged adults. I'm not going to go through all of that data. And the question I had was, well, is that true also for ApoB in young adults? And so this is our first kind of look at those data in the cardiac cohort, and we took ApoB in non-HDL and LDL levels at baseline, and we did what's called a discordance analysis. We don't have to get too in the weeds with what this is, but just the basic premise here is LDL and non-HDL are pretty highly correlated, but in some individuals, there's a discordance. They vary usually by more than like 5 to 10% in their sort of relative percentile. That's about 15% to 18% of most population-based samples. And so what we did basically is you take the subgroups, and you take the people that both are low and both are high, and then you have people where the ApoB is higher than you thought, and an LDL and the inverse, and you just kind of compare the risks across them. And you see, does that risk follow the ApoB level or does it follow the non-HDL level is the basic premise. We don't get too into, there's other ways to do it, but anyway, nonetheless, we took a look in Cardia, and we did this fairly crudely, actually. We just use a median split for non-HDL and a median split for ApoB. And again, we found about 9% of people were in the discordant high ApoB group, low LDL, low ApoB, high LDL, and the inverse, high ApoB, low LDL, again, about 8 to 9% of people. But then we looked at each one of those subgroups and looked at their association with coronary calcium presence in midlife. And basically what we found using the low group basically as our referent group, we knew that they were at the lowest risk and they were. Those who had both high ApoB and high non-HDL had odds ratios of about 2 approximately for having coronary calcium. Again, not surprising, we knew that. But when you looked at the groups that were discordant, so the discordant low group, meaning this is an individual that had higher than mean levels of non-HDL or LDL and lower than mean levels of ApoB, did not have a significantly higher odds for coronary calcium. But the inverse group did. So if the ApoB were higher than you would expect for a level of non-HDL, those people did have significantly higher risks for coronary calcium. And so our takeaway from that is there may be some added value to ApoB in terms of predicting subclinical atherosclerosis for young adults, which was consistent with ApoB predicting cardiovascular events, perhaps slightly better in middle-aged adults. So more recently, we're now, as part of my RO1, we've been measuring ApoB actually in participants in cardia really across the life course. And this is my fellow Alex Zeitlin, my clinic fellow, who's very interested in this question. Alex is actually taking these data and trying to compare, well, okay, that's great, John. If it predicts coronary calcium, does it also predict events differently? This is a harder analysis to do. This is our kind of first look at it. And this is just comparing the association, strength of association between ApoB or LDL particle number, non-HDL, LDL, and total cholesterol with cardiovascular events across the life course. So this is 35 years of follow-up. And these measures are being made, I think, in this analysis at year 7. So anyway, long-term follow-up. And if you use a kind of a risk model and you plug it in and generate different C statistics, there is no real difference. I can tell you we're now doing a discordance analysis. And frankly, the discordance analysis is really suggesting it's probably not much of a difference, if any, when you're trying to predict long-term risk. Point being, in young adults, probably not as important to quibble over which atherogenic lipid measure you make, but what's important is to measure something, right? And then more importantly, to interpret it in the appropriate age context. And I'm going to go into some data to help us understand that a little bit better. Another question that came up, and Will and I were talking about this when he was trading, is there, this question, like we're talking to patients and we'd say we need to get that lower, and they'd say, well, how low? We want to get to an optimal level. We're like, what is that? Very fundamental question. Turns out it's actually pretty hard to answer. But there have been a few studies looking at this. So this is Yi Zhang did this. She's out of Columbia, and basically using different ways to categorize LDL, either using a cumulative LDL exposure or a time-weighted average, which don't give you exactly the same answer, although they should. Regardless, if you use a cumulative LDL exposure, it's really just a straight line. I mean, there is no threshold below which there's no risk. Wouldn't expect there is. So lower is better. How low? As low as you can get it, I guess. When you use a time-weighted average, there's a suggestion basically of maybe a threshold around 100. Now that doesn't mean there's no events below 100. It just means that there's no stepwise increase in events once you get below that per level of atherogenic lipid. So I think maybe perhaps a threshold of 100 is justifiable. Dr. Schultz did this when he was a fellow, kind of looking at cumulative. We were looking at just a one-time measure in the lifetime risk pooling project and saw a similar kind of pattern where a value less than 100 milligrams per deciliter per year was associated with at least no escalation in risk above that level. So maybe that is the value. I did a similar analysis with ApoB. We just, again, measured this in a lot of people in the cardiac cohort, suggesting that ApoB values probably less than 80 are a similar kind of threshold. So if you are measuring ApoB and you want to know what a good target level for primary prevention, untreated primary prevention patients are, who are young adults, 80 might be a justifiable threshold. But okay. So another question we had, again, is like when measuring lipids in young adults, like how effective is, let's say, a one-time measurement in really telling you what someone's exposure is going to be? Like, can I really count on a one-time measurement to say, okay, I know what this person's likely to be exposed to or not? And so this is one of our first looks at this. This is with Carol Pensina in Framingham Offspring study. We did what's called a trajectory analysis. For the fellows who may be listening, this is a data-driven kind of modeling approach that tells you kind of what are the lines, like how many lines do you need, and what are the lines that best describe the overall patterns that we see in the population. Okay, it's a statistical kind of modeling approach. And what we typically see in young adults is we see tracking lines, sort of parallel lines that are upward trending. Most people are kind of going up over time. Those that are low tend to stay low, but increase over time. Those in the middle do the same thing. And those that are high kind of do, again, follow a similar trajectory. They just have a higher absolute value, which is true. And it turned out if you had 2 or more measurements that were in the high group, and by the way, high here is greater than 180. So that's a very high non-HDL, by the way. And that was 19%, I think, of the cohort. 19% of the cohort, at least in Framingham Offspring. So this cohort is known to have higher lipid values than you see in many other cohorts. Suggesting that, okay, 2-time measurements, you're pretty sure that someone's going to stay high. I would say two measurements of 180, I would agree, you're definitely sure. They're going to be high. And of course, the risks were substantially higher in that high group. But when I looked at this and really thought about it, there's sort of a paradox to these trajectory models, in that they tell you how you best describe the overall pattern in the population, but they may not tell you the true experience of any one individual, right, in that population. Comes up a lot when you're doing population kind of level work. But I got interested in what happens if we really look on an individual level, particularly in young adults? Is it really that clean? And of course, when you look at individual level data, it's never that clean. And so these are what we call spaghetti plots. So these are just individuals over every individual over time kind of plotted separately. And you can see there's a lot of people here. It's like 3,500. And again, I'm not going to have you make sense out of this. I'm just going to point out a few basic trends when you look at this. What we did here is we stratified these individuals by decile of first measurement. And so the lowest first measurement is in the top right there. And then we're going in progressively higher deciles across the top row and across the bottom row. And then this one in the bottom right is the highest decile of initial measurement. And we looked at how do these individuals change over time. And if you just eyeball it, what you'll notice is the highest group tends to come down probably the most, and the lowest group tends to go up the most. This is what we call regression to the mean. We see this a lot in epidemiological data. And I would say it doesn't mean it's not significant. We see this in clinical practice all the time too. And I would say in the sort of middle, more normative groups, what you tend to see is a sort of slight upward trajectory, kind of like what that model I showed you before showed. So yes, most people do tend to go up over time, but there's a few nuances too. And if I put all these deciles together and you looked at the range, the variance within that group of 20, these would be 25 at baseline, on average, 25-year-olds at baseline, the absolute range is actually substantially less than that range that you'll see in middle-aged adults. Right? So there's more variance across individuals in middle-aged adults than there is in young adults. Okay, like why does that matter? Well, what it implies is that an absolute difference in an atherogenic lipid level in a young adult may tell you a little bit more about where they're going than you may see in a middle-aged adult. So an absolute difference in a young adult may matter a bit more if you take a longitudinal perspective on the data. And that's not intuitively obvious. You have to kind of look and think about it for a while. And I'll show you some more data on that in a minute. Okay. I would say another point here is, as you can see at any one of these deciles, although people tend to trend up on an individual level, they can go a lot of different directions. And if you're wondering, we did sort of cross tables and said, okay, if we take their percentile at baseline and their percentile when they got to year 30, right? Like how many people, let's say, went from the top percentile at baseline to the bottom at year 30 or vice versa? And that was actually about 8%. So that's not an insignificant number of people. And then most people actually crossed into another, let's say, quartile, across life. And only about 20% of people really stayed high or stayed low. So meaning we're going to need to check atherogenic lipids more than once in people across early adult life. I don't think that's terribly surprising. That is what we would recommend every 5 years or so, but it's really important to do so. We can't necessarily be certain about where someone's going. So I want to talk a little bit about like which variance is really more clinically relevant for young adults. So when someone comes in the clinic and we check their atherogenic lipid levels, okay, obviously at that point, what we're doing is we're seeing where they are now. And obviously checking a one-time level is very good at telling you where they are now, right? And that's what we do for a lot of middle-aged adults, et cetera, where we have risk strata, we use risk stratification, et cetera, to kind of help us figure out whether or not therapy is appropriate for them. But I would argue for young adults, this is the kind of variation that's probably as relevant, which is where are they going? When you measure that person, they have a non-H scale of 110. Are they going to be part of that group that kind of slowly goes up over time? Are they going to go down, or are they going to go up and shoot into a very high level of atherogenic dyslipidemia over time? That's the variation that I think we really want to focus on when we're seeing patients, young adult patients, and assessing their atherogenic lipid levels. So I got a little more interested in this and thought, well, how can I look at this? I started doing some work trying to predict atherogenic lipid levels with precision using genetics and one-time measures. And I'll tell you, it didn't work. I tried it for a few months and we were getting nowhere with it. And then I realized, like, what am I doing? I don't need to be that precise. I just need to get a sense. Is this person going up and going to be, high at a level I need to worry about, or are they going to stay low or be somewhere in between? And so when I gave up on that level of precision, this sort of came to me that maybe what we should do is look at how well a one-time measure really predicts your cumulative exposure. And so we did this in Cardia. And so what we did is for each individual, we were able to calculate a cumulative exposure to atherogenic lipids. I won't go through the methods of how we do it, but we had 5 measurements or more in everybody, and you basically do a spline and take the area under the curve. And so you have these different quartiles of exposure that are represented by these different lines here. So that the brown is the highest group and the blue is the lowest group of cumulative exposure. And then we looked actually at the hazard ratios for ASCVD after 40, and those in the highest group of cumulative exposure had a hazard ratio of about 4.4 to 4.5 for ASCVD events after age 40. So again, very relevant in terms of their long-term risk, a very strong determinant. But the question was like, if you measure their first value, and that's what's shown here on the x-axis, that's their first non-HDL measurement, right? By quartile of exposure, you'll notice that there's a lot of overlap. A lot of people are crossing right over into different quartiles, and you see that, though we definitely see some separation. And those who had a first measurement here of greater than about 180 of non-HDL, well, guess what? They stayed in the top quartile, very consistent with that previous trajectory analysis. If you had an initial value less than 60, you also generally stayed in the bottom. That's not terribly surprising. So if you're really low and really high, you tend to stay in those groups, but there's a lot of crossover in the middle. But I was curious, about, well, how certain can we really be? Can we quantify that? But more importantly, can we come up with an absolute threshold to say, because you have to make these, clinical decision-making, we have to anchor in absolute values. Can we say this is an absolute level where we know someone is likely to be high or likely to be low? And if so, how certain are we? And so this is a little bit unusual, but what we did is we did essentially a simple logistic regression model and said, demographic adjusted regression model, and said, okay, how well does a one-time measure before age 30 predict membership in either the top or the bottom quartile? We got this ROC curve, which, as you might imagine, since the exposure and the outcome are kind of the same thing here. Like the model looked really good. We had a C-statistic of 0.93. And if you measured it twice, you had a C-statistic of 0.97, which is like unbelievably good. But then we took the Wilkins index, so the best sensitivity and specificity there, and said, well, that will define the threshold there. That's the value at which, we get, again, the highest sensitivity and specificity to predict membership in the top or bottom quartile. No one's really done it this way before, but this paper's under review right now, but hopefully the first reviewers seem to like it. If they're in the room, that was my impression. But anyway, so we had a threshold for non-HDL in young adults of greater than 135, gave us about an 85% sensitivity and accuracy, overall about 86% for detecting membership in the top quartile. I want to contrast that to what is often used, at least in electronic medical records, which is a cutoff of 160, right? Which that only has a sensitivity of around 50% or so. So again, arguing that we should probably interpret these values in a sort of age-specific way. By the way, 160 is the middle of the top quartile, just so you know when you look at middle-aged adults. Anyway, for LDL, a value greater than 120 seemed to predict membership in the top quartile, which had a sensitivity around 89% compared to about 72% if we use an LDL of 130. For predicting being in the bottom quartile, it was a non-HDL really less than, we'll call that 110, and an LDL less than about 100. So again, that threshold around 100 for LDL does seem to hold when we subject it to this analysis as well. But point being is that, again, absolute values that we'll use to define values as either high or low in young adults should probably be lower, right, than what we use for middle-aged adults, because again, people tend to increase over time, right? So if we're going to apply these thresholds we got for middle-aged adults, we probably need to age adjust them. Similar is probably true, it turns out, for blood pressure. And one of my colleagues, Nori Allen, is working on that right now. Okay, so you could say, okay, John, so early life risk factors are important, but hey, can we just wait until people are middle-aged to treat them? Can we restore them to the level of risk they would have been had they never been exposed, right? Maybe that's a reasonable clinical strategy. And I do think, by the way, that is a clinical strategy that's reasonable. But we looked at this in the MESA cohort, and briefly what we did here is we took a referent category of people who came into the MESA cohort with an LDL less than 100, who were not on statin treatment, who did not have coronary calcium. We called those our sort of like low risk group, right? And if you look at their event rates, they were the lowest risk group. And then we compared them to individuals who were treated with a statin to an LDL less than 100 who did not have coronary calcium. And we found that their event rates were not substantially different from the referent group, suggesting that if there's no coronary calcium, you could potentially restore people to the level of risk they'd be had they not had the level of risk they'd be had they not been exposed to high cholesterol in early life. But if you looked at people who had coronary calcium who were treated to an LDL less than 100, they were still at about 2.5-fold higher risks for events, right, after baseline. Now, this risk was lower than people who had calcium who were not treated. So there's benefit, no doubt, to being treated, and you should be treating people with coronary calcium with lipid-lowering therapy if it's appropriate for them. But there may be some opportunity cost, I guess, to waiting until people develop coronary calcium, right, in order to initiate treatment. And I think that's something that we should look into more and consider when making recommendations for treatment for young adults. And I would argue, by the way, that we've seen this for many, many years, because when you look in any higher risk primary prevention population, this is a survival curve from Jupiter, and this trial you're all familiar with. You know, when we treat people with statins, we don't reduce their risk to zero, right? There's still residual risk, right, in the treated group. And I would argue residual risk is really nothing more than subclinical atherosclerosis, right? We can't reverse that plaque. The thing is still there, right? And maybe that's what this green line's meant to represent. If those people had primordial prevention, right, had optimal risk factors throughout their life, maybe there wouldn't be plaque and we could actually reduce their risk down to a true kind of low risk state. I don't know that to be true, but that's what I would theorize. Okay. Is there any observational evidence beyond sort of, okay, John, higher risk associated with higher event rates? Is there evidence to suggest that treating atherogenic lipid levels earlier in life has benefit? Well, clinical trial evidence, you know, beyond what we've done with FH patients, you know, at least with moderate elevations, not really. However, if you do modeling, genetic modeling, you know, using basically genetic risk scores as instrument variables to predict lipid levels, you know, those who have a genetically determined low level of LDL seem to have greater benefit than those who have a treated level of low LDL, suggesting again that longer term low exposure is better than waiting to treat people later in life. Although I think that's largely mediated by atherosclerosis or modified by the presence or absence of atherosclerosis. Many of you are probably familiar with the concept of legacy effect, but this concept really came from long-term follow-up of some of the very early primary prevention trials done in the UK, where individuals were randomized to either statin or not. And then after the end of the trial, they were allowed to either discontinue statin therapy or continue therapy. And those that weren't on therapy were allowed to come on therapy, et cetera. And it turns out they got lucky and that the groups kind of rearranged themselves kind of perfectly. And then they followed them for about 20 years. What's so interesting is that the lowest risk group was the group that stayed on statin throughout 20 years. And the highest risk group was the group that never took statin over 20 years. But the people that took statin and then came off of statin after the trial, right, were somewhere in the middle. Right? So they still had benefit from the 5 years or 7 years, whatever, that they were treated, that persisted even 15 years after the trial ended, right? Again, very consistent with that cumulative exposure model, right? And the importance of minimizing exposure across the life course. All right. I'm taking another kind of look at this. This is my colleague, Kieran Coley-Lynch. He actually just joined the faculty in preventive medicine. He's a healthcare economist. And I won't subject you to a lot of cost effectiveness on a Monday morning. But what Kieran was able to model is that essentially treating young men with LDLs greater than young adults with LDLs greater than 130 with statin therapy turned out to be cost effective, right? In terms of from a quality of life, adjusted quality of life perspective, was cost effective. And for women with an LDL greater than 130, it was considered to be moderately cost effective with quality adjusted life years between 50 and 100,000. So interestingly, if you do the numbers, the financial numbers, this could be a beneficial approach. Another study I want to talk about before we get into sort of some clinical recommendations is this study by Mandy Marma-Parak, who's another colleague of mine. She's a pediatrician, actually, who does a lot with early life, obviously lipid levels in young adult, in children, actually. But she's interested certainly in young adult exposure. And this really speaks to the importance of recognizing and identifying the FH clinical phenotype or familial hypercholesterolic phenotype. And what Mandy did here in the Lifetime Risk Pooling Project, and let's just focus on women for now, we're here on the right, is she took people who had an LDL greater than 190 and called that phenotypic FH. And she compared their risks to individuals who had lower LDL levels, which we'll call less than 130 for this analysis. And she just looked at different ages of measurement, right? What were the event rates over time? And so if you look at, not surprisingly, of course, as we're doing with older and older groups, right? We had higher event rates, not surprising, you would expect that. And then comparing the blue to the gray bars here is the comparison across different levels of lipids. The gray bars are people with, phenotypic FAH. And so what you'll notice is like the relative difference in risk, right, for younger people is much greater, right? We were talking about this last night, right? How like the relative importance of lipids seems to be diminished a little bit in models as we get to older ages, but there's still an effect here, even up to 70 to 79 with that degree of severe dyslipidemia. But we're still looking at up to, 4 to 5-fold higher risks. But another important kind of way to think about this is at the level of using a risk frame, right? The level of risk in a woman with FAH who's 20 to 29 is about on par with the level of risk we saw with a woman with a more normative level of LDL who was 50 to 59, right? So a way to think of it is like, wow, after like FH level dyslipidemia can really kind of accelerate risk age, if you will, up to 20 to 30 years, particularly in women. So, when you see a young woman who's 28 and has an LDL of 220, it pains me when they get sent to me and someone said, oh, they're a young woman, we don't have to worry about it. I'm like, no, you definitely do, because she has the risk profile of a woman who's in her mid 50s. And I use this when counseling patients about the importance of certainly of treating severe forms of dyslipidemia. Okay. All right, so let's talk about what we should actually do, any recommendations. And as I said, anytime I talk about the recommendations here, keep in mind that there aren't a lot of clear guidelines as to what to do. So this is sort of suggestion, and some of it sort of based on guideline recommendations, but a lot of it's sort of a gray area. So certainly first is focusing on lifestyle and behavioral optimization, no doubt. Any preventive, obviously, evaluation has to focus on this, and I think it should first and foremost. I think there's also really important opportunities for education here. And if any people walk away from this talk with anything, I just hope it's when you have a young adult come into the clinic and you measure their lipids, please don't look at it as, okay, I don't need to treat this with a statin and say, you're fine. Like, I think there's so many more opportunities to educate them about the importance, again, of optimal levels, what those levels are, how to maintain them across the life course. I think that's vitally important. I think it's really important to assess the drivers of adverse health behaviors for the individual. This obviously can involve longer form discussions, but are really absolutely vital. And taking the opportunity from behavioral modification when it's appropriate, using motivational interviewing, other techniques. For the fellows that are listening and other trainees, I think there's a huge need for more research to really kind of dive into this. How do we optimize, how do we assess, and how do we optimize behavior, and understanding the various social factors that are driving people towards more adverse risk factor profiles, I think is really critically important. And then, of course, like any decision in prevention, we need to individualize treatment decisions. Decisions about pharmacotherapy, that's where you're going, they take time. There's some situations where people get started on lipid-lowering therapy, upfront, but often it's multiple trials of lifestyle and discussions of risk versus benefits to find the therapeutic plan that works for your individual patient. Of course, don't lose the forest to the trees. Assess all the other risk factors, tobacco use, including vaping. With blood pressure, certainly optimal values are also probably lower than the clinical thresholds that we use to define hypertension or not. Assessing a family history of premature CVD, assessing adiposity and insulin-resistant diet and physical activity are, of course, absolutely crucial in this population. So I get the question sometimes, hey, John, well, since risk factors have a strong genetic component, and we don't have a lot of sort of prevalent risk factor levels in young adults, the genetics really help here. And maybe to some extent, polygenic risk scores will, but at present, not a strong signal that that's going to really help us discriminate who's going to have an event and who isn't. This is my colleague, Sadia Khan, who many of you know. She's done phenomenal work, she's incredibly productive. And she had this question, and looked in Framingham Offspring at this question. And basically, if you add a polygenic risk score to a 30-year risk factor model, you don't see any really significant improvement in discrimination of who's going to have an event and who isn't. And I think I'm going to point out here is that the risk prediction models keep the risk factors in as a continuous variable, right? So they don't have this issue of misinterpreting a threshold. And so when you look at the effect of, let's say, blood pressure below 130/80, right, it still does a really pretty good job of helping you figure out right? Who's going to go on to have an event and who isn't. But who knows, maybe more to come on this. Maybe these risk models will get better. Okay, so when we're measuring lipids, like how often should we measure someone's atherogenic lipids? Well, most of our guidance would suggest at least one measurement, right, between age 18 and 25, and probably every 5 years, thereafter or sooner if it's certainly concerningly high value. I would suggest these are measures that are absolute levels that are justifiable to sort of call desirable, elevated, and certainly severely elevated in young adults based on some of the analyses and observations that we've made. So desirable non-HDL being less than 110, I would say anyone greater than 135 is elevated. And I think at least it's an opportunity to educate them about the importance of lifestyle optimization to potentially lower that level and lower overall risk. And severe being 220. As you all know, with LDL, it's a value greater than 190 or 160 if they have a strong family history or stigmata of FH. Definitely want to identify that phenotype. Those who have lower LDLs lower than 190 but are genotype positive for FH are still at substantially higher risk. So those are people we definitely want to identify. If you're not sure, send them to me or other lipid people. We're happy to help make this decision. For ApoB, there's some thresholds there, and certainly triglyceride. I'm not going to talk about triglyceride today, but that's an important population to understand just for the trainees. Obviously, when you're looking at triglyceride levels greater than 500, we do worry about risks of pancreatitis. You're sort of treating a different disease in conjunction with lowering cardiovascular risk. So careful assessment of risk-enhancing factors, which you're all aware of. Adverse pregnancy outcomes, very important predictor of longer-term cardiovascular risk. Chronic inflammatory diseases, South Asian ancestry, CKD, metabolic syndrome, and high LPA. How to mitigate lipid-associated risk. Here's some recommendations. This is from, by the way, a review paper that Neil Stone wrote in 2022, which, by the way, I think for those of you who are interested, very worthwhile read, a great read. Again, for people who have severe elevations, ruling out secondary causes of hyperlipidemia, people who are consuming severely restricted carbohydrate diets, high saturated fats, hypothyroidism, nephrotic syndrome, people with cholestatic liver disease. And if you rule all that stuff out, then considering statin therapy per our guidelines, which I think is something that I do regularly in clinic. For those with elevated levels, I think really important to educate them on the importance of lowering atherogenic levels, obviously first and foremost through lifestyle. For some of these individuals over time, for longer time horizons, regular follow-up, we occasionally do decide on lipid lowering therapy. It really depends and has to be individualized. And if they're optimal, obviously continuing lifestyle. What about coronary calcium? This question comes up a lot. How useful is that in young adults? Well, there have been some analyses, even in the Cardia study, showing that the prevalence of elevated coronary calcium, right, with at which exam this was, I think exam 10. And the average age here was 40. The range really was anywhere from 35 to 45. They saw a prevalence of coronary calcium of about 10%, suggesting that there may be some yield to that test. However, those who had calcium really had elevated absolute risk factor levels. So they were pretty clearly defined as high-risk people for starters. But so the yield, I don't know, I'm not so sure of in that population, because usually I can make a decision about treatment based on risk factor assessment. But what do you do? I get people referred to me all the time who have coronary calcium that was either picked, or young adults who got it picked up on some other scan. I would point out that any adult who has calcium, okay, under 40, has a very advanced form of atherosclerosis. That person's in the 97th to 99th percentile for their age. The disease has started. Those are people that I feel very strongly we really need to be aggressive about preventive intervention, optimizing their other risk factors and initiating at least moderate intensive statin to get them LDL less than 100, and certainly blood pressure optimization. I think I'm running out of time here, so I'm just going to quickly talk about patients with diabetes. Young adults with diabetes, about 50%, 25 to 50% have calcium in their 4th decade of life. The guidelines sort of suggest with type 2 times 10 years or type 1 times 20 to consider starting statin therapy. I personally don't wait that long. I don't see the reason to wait given how strong a risk determinant diabetes is. And with a family history of premature CVD, which often gets sent to me, just a few quick points. Number one, it's important to clarify the details of the event that happened to their first degree family members, what they think is an MI. Of course, as you all know, is not always an MI. In our clinic, we've picked up long QT, HOCM, familial cardiomyopathies, coagulopathies, and connective tissue disease that were all sort of the causes of sudden death. So just throwing them on a statin obviously is an inadequate evaluation We check LPA, ApoB, careful assessment of other traditional risk factors. As this group is all aware, LPA, highly heritable. To me, that's another sort of risk modifying factor that pushes me towards earlier initiation of lipid lowering therapy. And of course, and certainly very careful patient risk discussion with early initiation for some. All right, take home points. So thank you for your attention. Again, I hope I've convinced you that early adult life is really just a phenomenal opportunity for prevention. And it begins with a careful and age-appropriate assessment of the CVD risk determinants. Maintenance, if we can get more people to maintain optimal risk factor levels through midlife, it's by far the best chance we can provide people to extend their CVD-free health span. Cumulative exposure to atherogenic lipids is one of these factors that clearly is a determinant. And one-time measures of atherogenic lipids actually are very strong predictors of future cumulative exposure. We just need to interpret them again in the appropriate absolute levels in age-specific context. And of course, certainly everyone benefits from a lifestyle, but it's likely certainly that some benefit from early initiation of lipid-lowering meds. For those of you who are interested, by the way, here are some articles that I would recommend kind of taking a look at, very high yield, certainly for the trainees, if you're interested in particular in this young adult population. And I can clarify a little bit later, but since we're out of time, I'm going to stop there, leave a little bit of time for questions. Thank you so much.
All right, that was a great talk, John. First of all, we'll open it up to the floor. Any questions?
Yeah, excellent presentation. So important, the work you're doing, looking at the impact of the life course and risk factors, because we often encounter patients at later stages of disease as cardiologists. Just one clarification for the listeners and then a question. It's a typical question I'm going to ask on teaching rounds about non-HDL. And most of the time our house staff, don't know what non-HDL is. And we wrote a paper 15 years ago called Do the Math. We graduated from first grade, you can calculate it. And the cost is $0.00. So why non-HDL is an advantage? And then you talked about this life course effect. Any interaction between social drivers and social determinants of health and lipid measures as they impact risk across the life course?
Yeah, so your first question, I agree. I mean, the non-HDL, it's cost effective. It's free on top of a lipid panel, and the math is easy. I agree. And again, for most people, I think it gives you the information you need. As far as social determinants, I mean, I would say, and this is, I think, by the way, also one of the advantages of the new Prevent calculator, which I didn't get a chance to really talk about, but really kind of incorporating, information on social determinants and their ability to modify or moderate, the relationship between an atherogenic lipid or elevated blood pressure, et cetera. And I would say, I can't say I can think of an analysis that looked at that specifically, but the totality of the evidence is, absolutely yes, right? And that I do think that enough evidence, observational evidence is present to say that, the effects of, let's say, adverse social determinants on, let's say, inflammation, dysregulation of inflammation, and other risk factors is enough to argue that, yes, that is probably intensifying or worsening, the effect of an exposure of atherogenic lipid levels at any level. But I think that's incredibly important. I mean, one of the big, I think, advantages of the Prevent calculator, by the way, I didn't really talk about it, but they took race out, but are using a social deprivation index, to help us understand, based on zip code, to help us understand, cardiovascular risk, which is I think a real important advance, an exciting advance in the field of risk estimation.
So the comment about forest and trees. We live in a world of guideline-directed therapies where, in some respects, we focus on the forest, based on the data that's collected on doing specific tests. We also have patients that we see that often have tests for other reasons where there are incidental findings. And so my question is, how do you use incidental findings or incidental disease states that are associated with inflammation, say obesity and arthritis, finding on a CT scan that was done to rule out appendicitis that there's some atherosclerosis that was seen, or that there's fatty liver. And I don't hear a lot of discussion in managing individual patients about how we use these, quote, incidental things, and I wonder whether, and often it's hidden in the medical record, but the AI technology now is beginning to pull some of those things out of the hidden findings that are in the medical record. Appreciate your comments.
Yeah, no, I think that's a huge, I think you're bringing up a hugely important area and a real opportunity to identify those at higher risk. So I think there's most focus and data right now on the incidental coronary calcium, right, to your point. And there are various actually AI-based, I don't know where they are in like marketing right now, but I know there's like AI-based, they're there, okay. Yeah, AI-based approaches to pull out information on coronary calcium, either for directly reading the scan or language-based processing of like reports. And some, from what I understand, can quantify reasonably well, I think, if present, that it's there. I don't know, can they tell you there's zero? I don't think they can say there's zero CAC because, of course, they don't.
Basically mild, moderate, or severe.
Yeah.
There are companies that are in this space,
Yeah.
Both in terms of investigation, but clinical utility, but mild, moderate, severe from some of these incidental findings. Zero,
I don't think they
I
can
would
say
think
that.
there's still absence, basically, I would.
Yeah,
think,
yeah. I guess it depends on the kind of CT scan they're having, right? How many cuts, for certainly they got of the heart. But nonetheless, in this population, though, in young adults, I see this all the time. People get referred to me because of incidental CAC. And I mean, again, any adult with CAC less than 40, I mean, that is a person with advanced disease. Like, right? I mean, it's sort of easy in the sense you're like, oh, it's not easy in that what you do for them, but it's easy to know like this person's at high risk. We need to get rid of that disease. I'll be honest, I tend to treat coronary calcium as a binary variable too. I mean, to me, it's okay. There's advanced atherosclerosis there. I mean, calcification occurs late, right, in the process of athero. I know it's going to get worse. It progresses at a fairly consistent rate. So I think that definitely helps us identify people who are higher risk. And I have conversations with those individuals about, the appropriateness of lipid lowering therapy and see what they're comfortable with. So I'm a big fan. As far as like finding hepatic fats, if I probably had one or two people sent to me, with that finding, and I agree. I think that that's certainly helpful to educate patients about the importance of gradual weight loss, right, in the presence of NAFLD, and the fact that hepatic fat in of itself, right, is a predictor of like high cardiometabolic risk and ASCVD risk. I think is vitally important. So I think that's a great topic. Probably we could spend an hour going through that literature, but I couldn't agree with you more.
May I ask a quick question? I know it's late. Peter Blom.
Yeah, sure.
When I was at the MDH 1,000 years ago, I saw two patients with Tangier disease, and they still stick in my mind. My question is not so much what do you do with those, which is another issue, but my question is, that tells us something about the genetics of what's going on in relation to what we find when we do testing in these kids, these young people, who have HDLs of 0. So tell me what that tells us about the general population and what is going on with variable LDLs or non-HDL lipids. There's got to be something that connects those to the Tangier's disease at one end and somebody who doesn't have any genetic interaction on the other. Does that make some sense in the question? Is there something that we know about that interaction which can lead us into better definition of how to take care of people?
Yeah, I guess, I didn't really talk about the sort of genetic forms of dyslipidemia other than, FH in this talk. And the way I kind of think of it certainly is, we have the rare variants with huge effect, FH being the most prevalent of the rare variants, but then there's diseases like Tangier's, which, when recognized, it's vital, to your point, vital to actually to recognize that and treat that appropriately. But the factors that are determining kind of the distribution of atherogenic lipids across most individuals, sure, there's a genetic effect. I think the last study I looked at, taking in all the identified SNPs was somewhere around 14%, maybe kind of variance, but largely driven certainly by lifestyle factors. And to your point, though, I think there's a lot of interactions, right, between the environment and the genome that is determining the atherogenic lipid phenotype. And we don't know all of those, but we're starting to dive into that. That's one of the things our group is doing. I mentioned briefly, we're doing some epigenetic work, and that's one of the things we're looking at is like how are different environmental factors, differentially methylating promoters of genes that mediate lipid metabolism, to try to dive a little bit deeper into that. But at present, again, beyond identifying those sort of rare variants with large effect, I don't know how to kind of weave that into my clinical evaluation, at present. Does that answer your question?
Yeah, it just may be that as we learn more about that in fact, trying to figure out what that interaction is may tell us a little bit more about who is at higher risk with the same
some lipid level.
profile.
Yeah,
Yeah.
absolutely. Absolutely. And yeah, I think there's also a ton of work to be done on, right? What makes some atherogenic, in some individual, a level of atherogenic lipoprotein more atherogenic, presumably. Why do some of them get events and some don't, right?
Yeah,
Which I agree.
exactly.
I think it's related to these sort of complex interactions completely.
Yeah. More to learn.
Yeah, definitely. No doubt.
Thank you very much for that beautiful presentation. I would just go straight to the point. A young adult, calcium score of 0, and elevated LPA, statins or no statin.
You said, I'm sorry, calcium score 0 and high LPA?
Yes.
And what's their LDL?
Well, it's within normal range.
Normal based on this?
Yes, normal, let's say 80 or so.
It's a tough one. So we're talking 18 to 40 and a high LPA and sort of normative LDL. Well, so number one, these are tough. As I said, like everything sort of is to be individualized. What I use actually when I'm presented with that scenario is there a family history? I take a very careful family history. If that person has a strong family history, right? Particularly if there was a sibling, right, who had an event at a young age, then I'm much more aggressive in my recommendation for, if your question is about statin, about lipid lowering therapy, but I'm very aggressive in my recommendation for everybody, right? About trying to optimize cardiovascular health, currently all the behavioral factors that we can and all of their other, other risk factors as is guideline appropriate. But I don't think there's no simple answer right now. And it ends up being, a longer form conversation about their tolerance, right? For risk of an event versus risk of a medication. I can't give you a data-driven response other than that. I think we are working on an analysis to kind of see please don't scoop us, but to what extent you can attenuate LPA risk, right? With optimizing other risk factors, right? I think that there's a need to understand that, to help guide that very scenario that you're bringing up, which I think is really important and going to be increasingly common as we're checking LPA in more people with the advent of these LPA lowering therapies. Yeah, great question.
Keeping his patient in mind, where is your threshold for ordering calcium score test?
Oh yeah, sorry, I was running out of time, so I didn't get into it. I don't order calcium scans for young adults. I very rarely, in fact, I don't think I ever have. No, I have once. Order calcium scans for adults that are, under 40. The only scenarios where I found it to be helpful, I had a patient with diabetes who said, I don't want to take a statin unless I have calcium. And we talked about it. I said, well, I think you should take one anyway, because I don't want you to develop calcium. And so we did it for them, and they had calcium and then were willing to take it. So sometimes I've done it in very few scenarios to try to help guide, to help patients feel more comfortable with the decision one way or the other. But under 40, I think it's a pretty low yield test. You can identify the people that are going to have incident calcium by just looking at their traditional risk factors typically. And as I said, with diabetes, I tend to be a little more aggressive with treating them earlier. I don't see the point in waiting when someone has prevalent diabetes. And if they're smoking, it's get them to stop smoking. And that, to my mind, puts them in a much higher risk category. And I'm a little more aggressive. But again, the prevalence was about 10%. It's not wrong to do it. I just don't think it's going to be particularly high yield. It's a very low radiation dose. So I don't think there's real risk to the patient necessarily. But yeah. And by the way, that's men less than 40 and women less than 50 is usually the age cutoff where I'm less likely to use it.
All right, great. Well, thank you for a fantastic talk. Thanks
Thank
everybody
you
for coming.
I hope that was
extra
helpful.
early.
The preceding program is copyrighted by Emory University.